This is a HCC who has decompensated liver cirrhosis, LB3. So again, as we were talking about at the dosimetry talk, these are probably patients you wouldn't want to treat with radioembolization. Their liver disease is really more important. And in general, although this is not exclusively the truth, TACE tends to be better than radioembolization for less risk of decompensation. So for LB3s, we tend to use TACE.
Okay.
And so as you can see here, this guy has a TIPS as well. If you look at the angiogram on the left, it was placed at an outside hospital. We definitely did not place that TIPS.
I thought it was maybe like a DIPS or something.
Or something, yeah. No, TIPS. But you can see the 37 millimeter-ish tumor kind of in segment 5/8. And you can see we can get very selective. And again, the benefit of using this in TACE is that as you're embolizing, there's a beautiful paper by Johnson et al. In 2016. They were looking at LC beads and embolization, and they looked at the microvasculature throughout this course of embolization and what happens. The interesting part, not that I want to belabor with all of this basic science, but they saw that if you came to angiographic stasis and then transected the tumors and looked through the tumors, these were, I think, in rabbits, 54% of vessels were completely embolized and 46 remained unembolized. Again, talking about deeper penetration and more penetration of these vessels, even though we think it's angiographically static, you may not be getting all of the tumor microvasculature arteries completely full of your embolic material. And so this is one of those areas where I really would use a microvalve or something like that to really fill up those 46% of vessels, or as many of those 46% of vessels that are not being embolized just with traditional end-hole catheters. This is kind of an example of that. So these, again, I love taking the cone beam CTs before and after, and you can see with an end-hole catheter, there's, portions of the tumor that are less enhancing compared to when, in this case, I used a microvalve with more dense and kind of homogeneous filling throughout the entire tumor. And particularly, I like the capsule here. I feel like the capsule is a lot more visualized throughout the tumor. And so you can see that we are really going to get deeper, theoretically deeper penetration and more of our drug into that. And that's been confirmed in studies as well. And if you look at the necrosis afterwards, there's a nice paper by Titano et al. That looked at explant livers, and they showed that the degree of necrosis was quite significantly a bit larger with these microvalve compared to standard end-hole catheters. And as expected, you can see a non-enhancing tumor both on MRI and CT to follow. In this particular case, it was not super distal, right? If you go back a few slides, it was only 1 or 2 turns in order for me to get in there. I wasn't worried about getting super distal. And so in this scenario, I used a microvalve because, again, you have to prep a balloon. You have to make sure the balloon doesn't burst. You have to, there's a lot more that for that goes into a balloon microcatheter, but again, it can get more distal. So I usually start off with an end-hole catheter like we were mentioning earlier, and that allows me to map out exactly what I need to do. And then I can choose my more expensive catheter based on that.
Okay, got it.